Alrighty then, let's do blood pressure drugs, chapter 20. There's all your classifications there. And let's start with our ACE inhibitors. Um, when you're looking at ACE inhibitors, we're using them for hypertension, heart failure. So let's talk about what is important to know about an ACE inhibitor. Number one, page 247 has the cough related to this. Um, this is a classic NCLEX question. Inform patients of the possibility of experiencing dry cough, and if they have a dry cough, notify their provider. The provider would then determine to discontinue the medication. However, the patient should not just stop taking the medicine, because you can appreciate how they're going to be having hypertension if they would do that. But they should inform their provider that they have those side effects, so that the provider can consider something else. Now, keep in mind that, again, the provider is the one changing this, not the patient. If it's um, so on we go. ARBs, losartan is there. All the others are there too. And when you're looking at this, let's look at the adverse effects. Angioedema. Remember that this is a risk. It's teratogenic, so fetal injury is there as well. So they're not going to take it in the second and third trimester. And we're going to be monitoring these patients. They will be monitoring their heart. Stop. Monitor their blood pressure, sorry, and be able to take care of that. So on we go. The next greatest hit we have is a calcium channel blocker, and nifedipine, verapamil, diltiazem. What's important to know with these drugs is, if you look on page 251 and further, there we go. We're going to watch for an increased heart rate on occasion as reflex tachycardia. We're going to encourage our patients to watch for peripheral edema and orthostatic hypotension. Any of these blood pressure drugs, we're watching for bringing down that blood pressure too much, and they're dizzy or they're weak. And so make sure that that's something that we're watching as well. So let's move on to your alpha adrenergic blockers. And this is on page 253 and beyond. And so with this, again, orthostatic hypotension, you're getting a theme, right? Monitoring blood pressure and heart rate. And but with this drug, we're also going to take it with food. And sometimes in your book it says that the initial dose at bedtime to decrease first dose hypotensive effect. So hypotension is really important. Next one, clonidine, centrally actin. CNS depression, remember orthostatic hypotension. But this one we're going to add on the lovely side effect of dry mouth. Beta blockers. Metoprolol, we talked about that the other day. Atenolol, esmolol, propranolol. These alls are, please know, your beta adrenergic drugs, and these are very basic blood pressure medications to bring down the blood pressure. So we're going to watch for that heart rate to go down, the blood pressure to go down, but also we need to make sure that we don't bring it down too far. Remember, this is the drug that we're going to hold if the systolic blood pressure is less than 100. Some physicians actually will order 110. So look at the parameters, and remember, this is the drug that you want. It's quick acting, right? So we're going to give this drug in the morning. We're going to, number one, make sure we assess that blood pressure. But number two, we're going to watch for the effect within the short term. Read up your beta blocker. Please, please, please read it up. 259. And then we have medications for hypertensive crisis. And so nitrostat, nitroglycerin, nicardipine, these are the drugs, nitroprusside, vasodilation of the arteries, and it's going to happen quick. So we want to make sure we bring down that blood pressure, but we don't bring it down too much. So we're going to monitor the blood pressure and EKG while we're doing this. The other thing that we need to do is make sure we have a separate line. These cardiac drugs, if we're doing them a drip, they're going to be a separate line from anything else. So that's the patient that has, has a central line, but then also has another peripheral line and another line because we have different drugs running that need to be separate. This one has that you're protecting the IV container and tubing from the light, and you only hang it every 24 hours because it's running slow, but you don't want it to be hanging too long. So that's quick down and dirty of that. I'm going to publish this so I don't lose it, and then we'll go on to chapter 21.